Anything? We good? I'll call the meeting to order. Need approval of the general minutes. Another approval.
Motion.
Second. All those, any discussion? All those for?
Yeah, I don't know. Sorry, real quick. This is like typo maybe, John. It's like one of the motions was like Dr. Syrat motions and Dr. Syrat also seconded.
I'll check that.
Probably didn't happen that one.
Yeah.
Yeah, that's right.
I'll
Right.
Yeah.
I often
Sorry.
get confused.
I know you're
One of the
important.
colleague works it over and it's like, they're like, hey, Dr. Blake. I'm like, I'm not.
There you go. All right.
I
Okay.
think
That's
it's
it.
typo. Okay, so with that amendment,
Yeah.
any further changes? All those for?
I-
Any opposition? Okay, moving ahead. Program Agency Director.
So we wrapped up the annual conference at the end of February, had 110 people in attendance. We had 2 full days of pre-conference sessions, instructor update, a leadership program, and then the 2-day air methods, RSI, difficult airway class that we had 20 total registrants in that class. All in all, I think everything went very well. Everybody seemed very pleased with it. We're already have things in motion for next year already. Because snooze you lose with some of the speakers that we bring in. Dates next year are similar dates. They're 24th, 25th, 26th, and 27th of February. Same location at the Lakefront Hotel. And again, next year we're going to look at offering that difficult airway RSI class, potentially as long as we can get the attendance. I think from the LifeNet Air Method side, things went very well with the class. The students all seem pretty engaged. A couple of comments that I did hear is there was vast differences in the candidates as far as knowledge and abilities. But I think all in all, everybody learned quite a bit. Aside from that, we are working with some other partners to promote some education. The Mercy Flight Central folks have a 1-day CME session in Canandaigua at the Hotel Canandaigua on May 1st from 8:30 to 5. The registration flyer is on our website and also posted down in the hallway. It's got a QR code for registration. Cost of that is $35 per person, which includes a lunch. Additionally, we partnered with New York State DOH, and they are holding a recruitment retention symposium, which will be in Canandaigua as well at the Ontario County Safety Training Center on Friday, April 24th from 8:45 in the morning till 5 p.m. So just a 1-day symposium. Again, there's a QR code for the registration, which is on our website and also posted down in the hallway. And then lastly, for the outside education offerings, the Ontario County ARC is doing a first responder autism awareness training. That will be on Tuesday, April 7th at the Ontario County Safety Training Center from 9 a.m. till 3 p.m. That session is free of charge, along with the recruitment retention is also free of charge. Spaces are limited, obviously, for both of those. The last I had heard, there's spacing for the recruitment retention. There was, I think it's 120 people, and they were more than that fall. So that's all I have for that. Additionally, we are looking at bringing back a quarterly, like a traveling CME offerings. So if there's a physician that has a hot topic that they would like to present, or really anybody, reach out to our office with your idea and your topic, and potential dates in which you might be able to do it, and we'd be happy to see if that would work in the schedule. We're looking. We don't have a schedule yet. We have some topics and some speakers already committed, so that looks to be moving forward.
John, any questions for John? Release administrator.
I'll just provide a quick update since Danielle was unable to attend today. She's on her way. But currently we have about 24 students enrolled in the Stanley Hall Grown EMT Original class. That's the only class running right now. We do have 2 offerings for the summer. There'll be an academy style class here at LCC Geneva campus. There will also be a traditional evening class at the Canandaigua Emergency Squad. And then we're going to have classes for the fall at North Seneca Ambulance, Canandaigua Emergency Squad, and Ontario Ambulance.
And there's additionally, Danielle's got planned a bunch of preceptor classes for, she's doing a lot of them. The bigger agencies should have been contacted already to schedule their own sessions for their folks. Zach's nodding his head, yes, they have.
I know that she's been in contact with Kevin at our agency to get those scheduled. Do you know if she's gonna post those and when those are? Or if you're gonna post those?
As soon as I get the dates, I will post them on our website.
And they are going on the
Yeah, they
Facebook
will go
as well.
on social media as well.
I think we have some dates lined up in April.
Yeah, I know she did several at Canada Emergency Squad recently.
Could we just clarify, if you're already a Finger Lakes preceptor, you have to attend that? I know there was some confusion.
So there is the difference between being a preceptor for the Finger Lakes Community College paramedic program and being a preceptor for Finger Lakes Regional EMS Council for the EMT level classes.
Yeah.
So
I think Zach's referring to, there was conversation, if you had taken the preceptor program in the past, do those individuals have to take the new class? The answer is eventually yes, because there is a new way of documenting student ride time through a online app. It is not required immediately, but at some point it will.
So part of a preceptor update, per se?
I would, yes, for anyone that has already been and taken the training in the past, it would be an update.
You have a question? Did you receive any medical director reports?
So I spoke with Dr. Glick yesterday. He was supposed to give me a report for today, and I have not received it as of yet. He is working on a date for the next education committee meeting, likely to happen in April, would be my guess at this point. So as soon as I get that, I'll pump that out to the group as many times.
Okay. Just from my standpoint, a couple of things. I was asked by Music Light and Life Man to join a state tag on paramedical, working with your guy down in New York City with the long name.
Steve.
Pardon?
Scully.
No,
Depends on which one it is. Could be John Margaritas.
yeah, there you go. I think so. So We'll see where that goes. There's really no paramedical representation in CMAC, so they're trying to kind of break off from that and do their thing. So I said I participate. Also, over there's a printed forms with 2 proposed Remac advisories for quality. So I'm a member of the National EMS Quality Alliance, I think they're calling it. It's a group of EMS physicians nationwide that have joined together to push quality standards at a regional level. So it sort of aligns with the role I have at the Remac. They're trying to just align and standardize some basic EMS standards of care. There's 2 proposed advisories to be issued. I'm not going to go through the intricacies of them because I can just let people take a copy, look through them, see what they think, see what they don't think. I would suggest that if there are comments, it should come back through your office and then it can be forwarded to me so you can keep track of it.
Sure.
And then if it happens to me, then we should go a paper trail. So just in short order, they've identified the one major issue, and what they're saying is they're basically taking the issue of use of licensed sirens in an uncontrolled fashion as a public health and patient care issue, and it's really just intended to encourage agencies to get policies on utilization of licensed sirens. There's still some agencies in our regions that use licensed sirens to and from every single call. So I'm sorry, I didn't see you there. Oh, I missed you. I'll come back to you. And really what they're saying is the use of licensed sirens is a patient care intervention for critical time appropriate needs. So they're also trying to reduce the number of licensed sirens responses to a singular call. So you're not got 7 cars all going licensed sirens, even when one gets there. So you can read through it. I understand that there's no enforceability through the Remac in the legal state and in New York state, but that doesn't preclude us from recommending and following the standard of clinical safety here. So people can read through it, and then we can have a discussion on whether we want to issue it or not. The second one is using video VL for intubation rather than DL, and I think that that's now established as a standard of care across multiple specialties, but there's been no statement of fact in EMS. Again, it's not mandating agencies, and it's correct that these recommendations are for advisories are taken from the national recommendations. It's not intended to force any agency into it. It's to be used as a support document and a consideration document, and essentially elevate this as an issue in patient safety and patient care. So,
what do you think the feasibility of that is in terms of the number and the expense of those for agencies? I'm just curious. I mean, that would be the.
I think a lot of agencies have already gone to VL, so it's quickly become the standard of care. The evidence has now come to the point that it's overwhelmingly better, and it's not even like there's an overlap between the 2 groups. We've now got to a point that first pass with VL, even the worst first pass with VL is better than the best recorded first pass with direct. So it's feasible because it's already being done. Some agencies have had VL I know at Wayne County we've had ours for 8 years, and we're actually changing all ours out to our recording capability now as well. And I know that Mercyfied and LifeNet both
Yeah, I think most of our ALS agencies currently already have some form of,
and it's just in line.
There's
that
very,
much already out there.
good.
Yeah.
There's likely very few, without doing a direct survey,
And I actually recently, just to give you an idea, there's now a group of physicians regionally in an area group that these agencies that have complete VL with recording capability, the physicians are now, anesthesia and emergency medicine, are reviewing these videos. And it's pretty striking. It's really highlighting some teaching points and stuff that could be done. I actually kind of enjoy participating in that meeting because you get to see all 20, 30 intubations for the month that are done in these agencies. And I originally when we got them, we did not consider recording, but now we're moving to recording so that we can feed our own intubations into that system. So I think it is very a reasonable.
Sounds more feasible than I would have thought.
Yeah, and I think from an advisory standpoint, our job is to issue advisories that support standard of care and quality. Where, both of these things are not telling agencies how to do their job, they're just supporting agencies if they need a little bit of impetus to change or just to elevate it. So,
Doctors, not to, would it also be prudent at this point then, while we're considering this, is to also potentially consider creating a survey and making this a quality project, and just kind of get a gauge on where we are with intubation successes across the market, and then direct versus VL.
yeah, I mean, certainly we could probably establish who uses VL.
Well, and if we create all that, we can also ask the state to help us customize a report through their data collection to get a report on all the airplanes.
Sounds good. You want to work with me on that? I mean, it's like we're asking the state to do anything, we'll have androids and robots that before they do it. But
yeah, we have a significant dashboard that looked at VL versus VL over the years, and definitely VL won out by 98% success rate without hypoxic or hypovolemia first pass success. VL prior to that was about 78%, so it's rather significant.
And I did put the numbers, the most recent numbers from the meta-analysis nationwide, which are obviously got lower success rates. So I don't plan on asking for any, motions or anything, but I think it's essentially out for comment now, and then we can revisit it in the next meeting.
So comment back if you have survey, things that would be appropriate to monitor in a quick survey, conducted by the providers as they're doing it.
Well, there should be, the Gannett database should be able to collect all that stuff right from.
Yeah, so maybe provide appropriate questions that we need to ask the state to formulate our report.
When we say VL, that means both hyperangulated and standard geometry blades, or?
Right now, they're not specifying the related, the hyperangulated ones look to be a little bit better for EMS right now. But they're just, I think that the comp was getting over the VL component.
Okay.
Okay, so that'll be out, we'll revisit it next time. Do you have your report?
Actually don't have updates because they canceled the meeting because of the storm in New York City, but I anticipate we'll be voting on any protocol changes at the meeting.
Yeah, there was initially an attempt to reschedule it for March or April, but at our last meeting, Director Greenberg alluded to that it would not happen. So the next meeting would be in May.
Just the two for the investigations list. John Gomes from La Grangeville, New York, 25-year-old. Surrender certification effective 2/17. And Scott Sterling from Prospect, New York, which was suspended for 1 year. for violations of previously issued stipulation or order. So, repeat offender. Oh, so an old business, moving on, Remac advisory review. I didn't get the list, so to review.
Al, did you get it?
I did.
So,
Yes.
I'll send it to you again, and then we'll move to the ones that are in consensus. We'll just eliminate them from the roster and make a current table, and make sure they're all posted, both on the Google app and on the website.
Any other business? New business, Victor Farmington?
Yep, so Victor Farmington Ambulance was previously under the pilot IGEL program. They have submitted for like a permanent placement under the new guidelines from the state for the program. So we just need official motion.
Is that BLS or BLS?
That was the BLS IGEL project that they were approved under the state previously, the one that Hudson Valley did. That has now been removed as a pilot program and is now a standard of care for BLS agencies. However, there's certain requirements that they have to complete. And as one of them, they had to apply through the program again, have a Remac motion specifying that, and then it's submitted back to the division, and then they grant forward.
So, are there other agencies that have already had this approval? Or is this going to be the waterfall of agencies now here that is submitted?
It is eventually going to be a waterfall, whether this body wants to do it individually based or as a total. Currently, there's only been one other one that we handled last time, which was Stanley Health. I'm bringing them up as I receive them.
So you anticipate more applications?
I would expect more. Whether or not those agencies will take the time to carry that forward, I could not hazard that guess.
I mean, given that if that, I would make a suggestion that we deal with this by if we were in the program and had been approved as part of the pilot program, and you're wanting to move to the permanent program, that we shouldn't have to go through every agency and we shouldn't have to wait 2 months to do it. It just seems efficient for the Remac to sign off and just allow the agency, the program director to approve it as long as the criteria are made. You know what people's thoughts are, voting members.
I agree with that.
It's just, I don't want to be here just going through every agency.
Well, it speeds up the process a little bit too.
Yeah, that sounds good.
Okay.
Yeah, if they were involved in the pilot, they're meeting the requirements.
So there was regionally, I think there was only 6 or 7 agencies that were part of the pilot. So in theory, there could still be a few others that submit to join in.
Well, it's,
My recommendation to all of them as we get the inquiries is to go on the state's website and pull out the training module that was approved previously by both the Commissioner of Health and the Hudson Valley, which is where the IGEL program started. Have them, because it's already been vetted, so have them complete that training and follow those processes, and then submit all that stuff.
so the motion could just be to approve the program agency to advance people to IGEL. If we support the concept of BLS IGELs, we could just transition it over rather than have them come back and say they did the training, they did the da-da-da-da-da.
Yeah, I mean, I guess my question would be, I think the initial proposal of putting it forward for folks that have already been in the program makes a ton of sense. Is there, I mean, I guess, what were the additional hoops that were required to get into that program, and do we think that that's
So there was
reasonable?
an initial application that the folks had to do. There was a prescribed training program that all the technicians at that point had to do, along with an associated skill sheet that was conducted. And then they submitted all that, and then they were approved to join the pilot program. As long as they're submitting data and everything back to the lead agency. So Hudson Valley at this point was that agency, and I think they're still collecting the data. That I'm not sure of 100%.
So I guess the reason for my question in that fashion is, is there a reason to handle the group who didn't participate in the pilot significantly differently, or if they're checking all the boxes and getting all their paperwork together, is there really a reason to not just kind of approve them as they come along as well,
So
if they've got all the requirements?
I believe the intent was, because they were not part of the initial pilot, that by having the Remac go through the approval process, they were in turn reviewing the training plans and et cetera for agencies that may be brand new to that and may not be following the prescribed training. Just to ensure that eyes are on the paperwork and they're not looking to do something, that's out of the ordinary.
So I guess if we're,
Because one of the requirements was waveform capnography. And there's very inexpensive handheld waveform capnography devices on the market now. So that should not be an obstacle, but do they have,
sure. So I guess then we say if they're part of the program and have their I's dotted and T's crossed, or they are a new agency that's following the same outlined training program and has all the requirements, is there a reason not to kind of green light them as they apply as well?
Yeah, I think as long as they're following the exact prescribed training process, I'm good with that.
If they come in with something else, then I think we've got to bring it back and talk it through. But if they're
Correct.
following the prescribed, list and letter,
The established standard.
yeah, then I guess I would
I would agree with
no objections. I guess my motion would be to support the folks that are in the pilot and those following the prescribed training plan and organizational requirements.
Second.
Yeah.
Mike,
prescribed training.
any discussion?
However you want to word that, John.
All those for?
Aye.
Any objection? Motion passes.
Can I just get who motioned and seconded?
Colin,
We're using too small there.
we've been called worse.
That's
like nursing.
You should probably call you behind it.
No, nursing's brutally honest.
Any other new business? I would say that, over at Auburn Hospital, we opened up a cath lab. We opened up our cath lab at, mid-January, and we did our 100th cath on the 1st of March. So we predicted 50 to 100 in the first 6 months, and we got 100 in the first 6 weeks.
How many cardiologists do you have doing them?
5.
Okay, so you generally want on call for semis and so on and whatnot?
24/7, 365.
Great.
STEMI call. North Seneca have been bringing us some interesting patients.
Always opportunities.
But I mean, I think that from a regional standpoint, it does present an opportunity. That we're aligning with the standards of door to balloon time. And if you said, like in Auburn, if you are going to Syracuse, so St. Joe's is not only a destination in the Syracuse side, and RGH and Strong on the other side, but if you're sitting in Auburn, it's a 45-minute drive to Syracuse. Our door to balloon time has been running about 30 to 35 minutes. So we can have the balloon up and done and the balloon pump in before you even arrive at the hospital in Syracuse. So I think that it does make it interesting for Geneva area, for Seneca Falls area, for North Seneca.
Because anybody that stumbles into us, we're typically giving lytics unless there's a contraindication,
Yeah.
just because we know if they land with us, most of the time it's a walk-in or something that develops while they're there. But by the time we pull the lever on, getting EMS, even if it's air, the times.
I think the challenge from emergency medicine standpoint is that's great unless they're in cardiogenic shock.
Yep.
And really, so if you've got someone with a STEMI and a pressure of 70, lytics they're probably not at the point that lytics are going to, because even if you clear out the blockage, you're still going to get cath and they're still going to get transferred, and they're going to need a balloon pump or an impella or some form of LVAD. So it's out there as a resource to this region, and I think it's just worthwhile considering. I am not in permission for that. In fact, the paperwork has been a nightmare. But, and then the other thing would be, although you've got, the guys are tied up, GD started tied up with Strong, it does present an option for transfer as well. And you know how it goes with, you don't have an ambulance, you don't have a helicopter. I know that when I was up in Oswego, we routinely would be blocked by St. Joe's who just said they didn't have capacity, and we'd be looking around. So it is out there. And it is a fully fledged, signed off STEMI center.
You've gotten a couple questions. There's been a couple conversations just about Pulsera, just if, when, how, etc. Anecdotally, just talking through things with the community and RGH shops. They're seeing most of the agencies using it in the area. Unity, a little less consistency with some of the smaller agencies out in the western side of the city. And, the feedback's generally been it's working okay as long as folks are using it, but it can be challenging when they're getting, different call-in methods, different methods of contact. So that said, I think we're at a point where our system has gotten the initial bugs worked out, so to speak, and we are at a point where we can advocate for getting the hardware and software and such on board. Just looking at the region and saying, if we're going to do that, would want to have that as the general and consistent method of communication, understanding that not everybody's going to be able to get on there, and not everybody will get on there, but in talking to some of the agencies, there's some feedback of, patient perception of you're sitting on your phone the whole time and so on, that, that not everybody's got the warm and fuzzies about it, so to speak, to jump right in. So that said, I just wanted to kind of bring that up, that, we've gotten the ask where we are at with it. I know you've been in a couple other conversations, but
yeah, I think that sums it up well. I think you need EMS buy-in, obviously. It's a two-way street. I think that it's not that difficult for us to incorporate from the hospital end, but obviously you guys, in terms of looking the pros and cons, our willingness to jump in is probably most important.
Well, most people are using it because they're using it when they go to the city anyway. Both Syracuse and our established, and also our region strong. So I know for Wayne County, everyone uses it, and so I don't think it would be a leap. It would actually make it a little easier for communication, just from Wayne County standpoint.
I think there's a lot of differences though on where you go and what they require.
Yeah.
Because biggest concern to me is workflow, especially you have one person in the back of the ambulance. Now I gotta type all this information on my tablet. And then I gotta type the same information on our PCR. Who's getting this? Did they receive it? We're really taking away patient focus on a lot of stuff.
well, and that's part of that's the patient perception.
But there's other times that in other agencies I know that are basically, sending an alert. There's no patient information. It's basically 18-year-old male, BLS, stable, ETA 15 minutes. Depending on what, fell from a roof or something like that, or, 5 feet. To me, that's pretty quick and easy. and at least you guys know what's coming. I think our provider's picking up the phone and calling you guys all the time for the calls we deal with is a huge waste of time. And I also think our providers got away from the old style telemetry reports, you know, using soap notes to verbally communicate when they walk in and give a report to a doctor. Because if you looking through, you know, the PCRs and narratives alone, they're all over the place. Usually you're not consistent. So I think there's some pluses and minuses to look
Well,
at.
I mean, what you just did, you know, 18-year-old male, 5 foot, fell off ladder, you know, stable, you know, right lower extremity pain. I don't think we'd be looking for any more than that personally, but
Can we kind of start that now as just a general standard? It's the information the hospitals need, because, you know, even ALS, it's routine ALS, unless I'm getting orders or requested orders from someplace else, you guys should know about it. But in all honesty, what are you going to do until we get there? And this way, it would also help us on the quality side, is knowing that, you know, if, wow, this provider B has gone there 3 times and we're having these little clicks, well, maybe we need to keep a little bit of focus on that individual provider.
in some of the anecdotal feedback from in the ask of focusing the reports, in chatting with our nursing teams, anecdotally, there is some feedback that there are certain crews and agencies that will report a vital sign stable and will get there with somebody with a pressure in the 80s, not inconsistently, not infrequently.
And I'd love to know that.
Well, and that's why we ask for those every time, and we get one here and there, and those certainly go to Mike. I think he's typically reaching out to agencies with those questions whenever they're popping up. So we will certainly keep those coming, but that, admittedly, I think some of the nursing team that's been burned on 1 or 2 of those, or has felt a certain way about some of those, has then generalized that feeling and is now asking okay, no, I want the numbers. What are the vital signs at present? And recognizing that although we've kind of become accustomed to that called level of service and level of report from the EMS agencies in the region, and strong in RGH, unless it's a STEMI, unless it's a stroke, like, you're not even getting a call. You're getting the Pulsera with whatever the team sends in, good, bad, or otherwise. So I have a right answer, just kind of starting to just chat that through. The generator's having a tough time.
I had a conversation with Pulsera about the app, and how much, since it goes on everybody's, for the most part, personal phones, so if there's any tethers that gets into other data, it's data mining or anything. You know, a couple of doctors were on the email stream, never could get an actual answer on that. It kind of got bounced around a little bit, and then when we brought up liability on our end, that kind of got bounced a little bit. I mean, to keep me honest, John, I mean, you saw those emails. The hospital end, they talk greatly about liability coverage because the hospitals are purchasing the program, so they're the purchaser. But for all of us who are not purchasers, they never could really answer my question about liability. Just as an FYI.
What's the specific question?
The question was, since it's an app on your phone, and most apps have, and I'm not an IT guy, so bear with me, kind of have like little tethers that can actually data mine other information from your phone for cookies. Yeah. So I asked that question, does this have that to go anywhere else in your phone with things? The salesman kind of bounced, never answered that question to say no. And then when I started asking some questions about the liability, I don't think she even answered that question very much, other than all the information that I could read through, all the writing. We're talking hundreds of pages of legal work. It's a great structure, and it's quite exciting. But it covered the hospital, like the doctors who have it because they're part of the hospital, like complete liability is covered. It almost like wipes that 1,000 million times because you're a purchaser, but it doesn't say anything about non-purchaser.
cell phones to call the hospital?
Yes.
What happens if they don't want to use their cell phone to call the hospital to provide you with one?
We have not created, we haven't had that issue yet. And technically, since it's been a non-issue, I mean, that'd be the same way for me to write an SOG. What happens if a volcano blows up on Main Street?
We utilized it, we didn't have any of those concerns, we just put it in place, and the key thing, I think, from an agency standpoint is full information. And I think if you get an age, a presenting complaint, and a set of vital signs, that's enough for a hospital to be like at an arrival time. What I would say is, from a quality standpoint, it's been helping our agency, because when we say you never told us about the trauma patient coming in, when we say actually we've got 3 different Pulsera alerts that you received. But it is true that everyone got used to the 340 reports and this big narrative, which was just as inaccurate as the Pulsera reports were. You know, they can tell you a wrong blood pressure on the cell phone or the 340, or they can.
It's one of those things, is when I share the information, that's just information because it was like an email thread, and I didn't want anybody to have to keep backtracking what we did. We just kind of ended it. I know a lot of people are using Pulsera, but the other question I have is, honestly, in the end of the day, I see the advantage for hospitals. You know what's coming, and you get a little bit of a tidbit, no matter how much they weigh or little. What's the advantage for EMS, though? Because when we walk through the door, we stand in front of a desk, the charge desk usually. We have to give a same report, no matter, even if we called, even strong, even you do Pulsera, you're still having to give another report, and then you gotta wait for the room. Every hospital's busy, so you're waiting for a room for the most part. You get to a room, then the nurse wants another report, and then if you're lucky, the doctor or provider will come around the corner, and they would like the 3rd report. So I'm just trying to figure out, at the end of the day, when we talk as Remac for emergency services, what is truly the advantage for EMS to use Pulsera? Like Al said, if it had a tendency to portal or port into our charts and information, that's an advantage for us. So
the only advantage that I saw was, when we were talking about it, was that if you do have a STEMI, you can send your 12 lead and have your cath team ready ahead of time.
I'm just thinking, I know one of the biggest problems that was going around in a different region was that someone actually took a screenshot of the Pulsera report that was sent, because you can add pictures to it. So if it's a bad record, there's a trackment, we can actually attach a picture to Pulsera and it goes to the hospital. And it was kind of scattered all over, especially with an agency's name on it and stuff like that. So they were concerned about the functionality of somebody using that on their own device.
Well, that's it.
Yeah, without blocking it out. But again, you know, I think workflow needs to be addressed a little bit more on the EMS side, because we're kind of repeating ourselves over and over and bouncing all over. So if we could come up with a policy that the hospitals would be happy, ALS, we want this information, BLS, we want this information, you know, something simple that we can train our providers. So even if we continue to call or whatever, you guys are getting the required information you need, and then once we get there, let the provider talk to the nurse, give the report, and if there's issues, to identify them there or pass them along so the agencies can see them. Because we have, all our agencies share providers, all our agencies have great providers, and all of our agencies have issues we got to address. Usually when you get into bigger meetings like this, it's about an agency, not specific individuals. And we also don't know, okay, they're having a problem with one hospital, why aren't the other hospitals discussing this? Is there really an issue? It just helps us fine tune and address training issues as we find them.
I think when I worked in the ER, we used Pulsera, and I know that for my personal workflow, when the Pulsera alarm goes off, I was going to go over to see what's coming in, and normally the charge nurse and the triage nurse do as well, and registrations. It does trigger some stuff earlier. It probably reduces our arrival to bedtime, but we're not resource limited at Auburn as much as other places. The other thing that I would say is I'd just speak to Monroe County because they established a standardized EMS report a while back, and they have training for it. I think it's still on their website, the Flremsc website. But they went with the same national, I can't remember the letters they used, but they went with, was it?
It's a MIST report.
MIST report.
That's what we're training EMTs, paramedics on initial education. Strong has requested that their Pulsera be given in MIST report. It's what's being done on continuing education now. So I thought we had already standardized the report.
So they've already addressed, so that might just be an easier adoption. It's just, might as well make more coral and steel than a pepper. So.
Are any hospitals in this region using Pulsera right now?
Thompson's fully integrated.
Thompson's?
Yeah, it's just from an operational standpoint, we've only allowed Pulsera on company-owned phones, so we don't allow providers to have it. We have specific phones that it's on, we have specific desktop workshops that it's on, so that we're not getting folks at home that are not on staff checking in on Pulsera. For our standpoint, we're seeing a lot of Livingston County that's working really well. We're seeing Wayne County a lot more often as well. Just from our standpoint, we're just looking for a very basic, we don't need a narrative, we need a just very basic MIST report. It was my understanding when Strong said we're gonna buy into this, that Pulsera was gonna have a standardized MIST form that you could build into it, so that you were just literally clicking a couple boxes, putting in a set of vitals. From a BLS standpoint, we don't need a lot of information other than just really what they're coming for, a set of vitals, and arrival time. I'll say from the ALS side, we have seen some benefits if we have patient identifiers because everybody essentially is on Epic, so we can start pulling some of that Epic data, and for our providers, it just allows us the opportunity to pre-reg and then start pulling some history. And so we can start developing some other kind of plans of care prior to arrival. But we're here to support whatever on the EMS side. So far, we've gotten pretty good feedback. Operationally, we've had a little bit of issues because each individual has to have their own individual login. So while we're using shared company-owned devices for security purposes, everybody has to have an individual login. So we're working through that process. So that again, if we have quality issues on our side, I know specifically you weren't supposed to be acknowledging that call, or whatever that is, so we can track down those quality purposes, and that's how you are learning to build. So
I'll add, people, as Al said, there's lots of people at different agencies. You have to have individual logins for those individual agencies. You have to have individual email addresses.
So
that can prove
if you want to trial it, though, Wayne County's already using it with no issues. It's 10,000 calls a year, so. Want to give it a go and just see how it works on your end, and we'd be happy to trial it.
And I think the last tidbit I would just say is we are finding, and I could be wrong, this could be from the EMS side, I think you can trigger that report, but if you're in a position where you don't have maybe enough cell service, I think it automatically fires once you do. So I think that may also be some of the benefit, and I'm projecting, that's what I've understood. So there's just that little tidbit for those of you serving in areas that don't have a lot of good service, that you're waiting. I'm thinking of Naples, they're waiting until they get up towards Cheshire before they call. They can fire that leaving Naples, and whenever you get that service, it fires off that report.
If you're waiting for someone to pick up the phone, do you guys feel like it would be, if you're giving the same amount of information, and it's whether a phone call or a text or the app, do you feel like it would be simpler through the app, or because then you can just fire when you get service, or you're not waiting for the nurse to pick it up at the hospital? I would assume that would be annoying.
So, the biggest issue we have is exactly that. And we can do the report and send it, but it won't happen until it gets service, right?
Sure.
And if we don't see an acknowledgement, which we won't get if we don't have an immediate send on that, we're going to make a phone call anyways.
I see. Okay.
Oh, I definitely think your medical should be the kind of their own on this.
Sure. Okay. Fair point.
Yeah.
Yeah.
No, don't say that, because he keeps asking the
Right over the Catskills, I have.
But I gotta remember my login.
Okay. All right, thanks.
Any further discussion?
Do you guys want us to look at anything to help you?
So, I think at this point, I didn't realize there was as much standardization as in terms of what is being reported or what is being utilized for the call-ins in the city. So the conversation I'll have during our next EMS directors meeting is a little more focused and asking, how that's going. But I mean, it sounds like there's some appetite for it. And to be fair, what we've done in the eastern region and in a lot of the smaller centers is the call is always the fallback. So if we've got an opportunity to improve efficiency for some or even the majority of the crew, probably the right thing to do, knowing that the phone call's the fallback and will remain so. And if we can make things a little better for the rest of the squad on our end and your end, probably the right thing to do.
So I think that this feedback is helpful in terms of just, it's a somewhat related topic, but giving the report 5 times sounds annoying, and I'm not as, now I'm more aware of it, because you said, you know what I mean? So that can be helpful in terms of possibly improving something in terms of the hospital process.
So we'll dig in with our folks. If we have questions or need anything from EMS end of things, we'll let you know, but otherwise we'll plan to bring you an update back next time with our current status.
Are you guys looking into, by any chance, accepting 12 leads from agencies, transmissions?
Like a different way other than Bolsonaro?
Yeah.
So-
Actually through the monitor?
So through the monitor, I mean, I know we've looked at like the Muse system a couple times with that.
So what is it, LifeNet?
LifeNet.
LifeNet through, I know Rochester can take that, but
Yeah,
You know,
we telemetry and then 12 leads to patient radios.
is that something we can do? And the reason I'm thinking of that is whether we like it or not, we're seeing a downfall of paramedic providers and more BLS rigs on the road from all of us. It'd be nice if there's a chest pain, and even if it's BLS, for them to send a 12 lead to you guys.
And even talking to the monitor manufacturers, they're expecting to not even offer printers on most of the LP35 in like 5 years.
Sure. I think Pulsar would probably be a dead.
Well, that's one of the options we use. It's either snap a photo on Pulsera and send it, or we can telemetry right from our Zoll.
Nice to just transmit.
Yeah, as long as you
Yeah.
got service. That's the other
Yeah,
problem.
we can also-
I was gonna say, everywhere but Auburn accepts the LifeNet transmission, or all the cardiac centers, I should say, like Geneva, Thompson, Clifton, Newark.
Thompson does not, I think.
Do they know?
We don't have the LifeNet capabilities, but it is a strong conversation with Pulsera. So our goal is in the near future to receive it either way. We're just trying to figure out which way you as a community are going, because obviously the costs are not insignificant. So we want to standardize whatever your standard is going to be as far as transmission.
I know that's been a barrier for BLS 12 leads at my agency, because they're, we'd rather send to the closest, most appropriate, instead of just sending it to Strong with them thinking it's a city truck, because they don't know where we are.
So I guess so RGH is getting transmissions?
Yeah, they have LifeNet.
I don't know that any of our EM providers are seeing, I'm not sure where they go, but I'm not confident that those are.
In the cloud.
Well, that's my point.
Rule just says you have to receive it. You gotta look at it. He said it.
They
just have to say.
I guess I haven't worked at RGH in 2.5 years now, but if it's been in place longer than that, if it's a newer development, I'm happy to ask, but I can't say I've ever heard it discussed or talked about. So I'm not sure where those are going, but happy to ask those questions.
Yeah, right, good idea. Let's send all of my 12 leads again.
Right.
I was gonna say,
Or even better, where they're going.
So ours,
But I got a phone number.
so right now, RGA system is errored out.
So our Pulsera goes, we have 2 desks to charge a provider, and then our triage is always our tertiary. If nobody's acknowledging, triage is supposed to acknowledge. So we would have, if we go LifeNet, we would upload LifeNet, but we already have Pulsera on those 4 locations. Again, we only work with U of our own, so it won't go to an individual individual, personally owned devices.
Yeah.
Like I'll never get it on my phone. I don't have Pulsar on my phone. So it would go to one of those four. If we go to LifeNet, we would probably just need
Our
to
team is
on our
currently
side.
carried out on receiving LifeNet transmissions.
As far as any type of acknowledgement or anything like that. When I worked in New Jersey, we just clicked that we received it. So I don't know if it's the same in LifeNet. That's how Pulsar works. So.
Yeah, it'd be nice to look at this and just standardize this.
Yeah,
across the
I mean, I think
region.
I can say that since Pulsar came out, we do use that more for transmission than the monitor, because now you can Pulsar monitor this, that, and everything, and then your patient's dying because you're sending all this crap.
Yeah, why did your patient go, I was trying to take
I know.
pictures.
Right. I was trying to let him know the patient was sick.
So my understanding for LifeNet at least is Pulsar was supposed to solve that issue with acknowledgement, because LifeNet is a very passive process. At Strong, it's just a computer on the side where it pops up. Most people don't even know it exists over there. So you can send as many EKGs as you want, but if you don't know it's coming, no one really acknowledges it. But Pulsar at least tracks it, so you know that someone's acknowledged the EKG, so you know someone's looking at it. So the hope is that with Pulsar, at least, I think as a region, we don't let BLS providers send EKGs because there's no reliable method for the receiving hospitals to receive them. But Pulsar here solves that issue if there's wide adoption. So.
That's the same patient guide. Pulsar was meant to be, the term we use is interactive.
Yeah.
So if you have a BLS screw that they send you a 12 lead that's significantly concerning, we can provide that feedback that they're getting resources, whether it's arriving in the field or we're ready for them to arrive without certain services being provided because they are BLS.
And I think from a provider, you walk in a house, grandma's complaining of chest pain, it's a BLS crew, you know, you're close to ALS 20 minutes out. It'd be nice to hook them up to the monitor, take a picture and send it. You know, so somebody, yep, patient wants to go to Newark, and they're engineering, no, maybe you might want to go to a closer facility or X, Y, Z.
I think that's the whole point of Pulsar, is that can be.
And I think if we're all in the same process, no matter what it is, it's gonna make everybody's job easier.
Does Pulsar allow?
BLS EKG, so there's a whole other discussion.
Yeah.
Is that this body has to approve it, has to approve the training module, et cetera.
To perform a 12 lead or to interpret?
For BLS.
BLS, even put the leads on.
Right, correct.
Okay.
But most of our agencies have ALS that says they don't want to do it.
No, I understand that piece, but some of the discussion is BLS 12 lead, that's a whole nother avenue.
Well, it's coming.
I don't disagree.
Yeah, it's just that.
However, there's a lot of steps that have to occur prior to.
All you're gonna need is one in the back, you have Waymo ambulances, it'd be a great time.
Yeah, great.
Does Pulsar allow EMS crews to talk to each other? Do we know? Like if you're a BLS crew, you think you're in over your head to talk to ALS? and be
I
like,
think
this
it
is
only
the-
does it if you're all integrated on the same call.
Okay.
Like John was saying, like, if we do a rendezvous with them to take a patient, we will ask them to send Pulsar typically because we would self-service in the air.
Okay.
But we're all connected through the same call.
They hand off, right?
Yeah,
They hand them off, yeah.
Yeah, so we can,
Sort of an old partner, they hand off the Pulsar.
so like our Pulsar account is partnered with LifeNet, and I think Mercy Flat, I have to look back at my system. So that way, if I know LifeNet's coming, they are involved in that thing, or should be involved in that thing pre-alert. So that way, the patient gets handed off on different levels.
Yeah, and if we request them to send it, then it says they're coming by air, and it's UTA and whatever. And we can send an update on the same thing if there's a change.
Any further discussion? Any motion to adjourn? Sorry.
Should be done now. Well, we torpedoed this nice quick meeting.
That was good.
I'll take that as a motion and a second.
I appreciate the conversation, all, helped us do some learning.